Hey everybody, what's up? Today we're going to go over advanced stage endometrial cancer and adjuvant treatment. So we're back to this kind of beginning phase, and let me get the pointer, but I'm going to lead you down the surgery path again here. So remember last time we went over stage 1 and 2. So let's say you do your primary surgery and your patient ends up being stage 3 or 4. So based on NCCN guidelines, you can give systemic therapy plus minus EBRT plus minus vaginal brachytherapy. So let's break down the different studies involved here and when to use what. So I made this graphic here, which you may or may not find helpful. It's very busy, but it kind of goes through the indications for each trial, which stage and when to use. So we have stage 3 here, which includes Portec and GOG-258, but also GY018 and Ruby, and breaks down the stage 3 categories here. So Portec and GOG-258 include all stage 3, and then GY018 and Ruby have their own subcategories. For stage 4, Ruby includes all stage 4, and then GOG-258 includes 4A. GY018 has different breakdowns for 4A, 4B, and then we won't go over a lot of higher grade histologies, serous clear cell and carcinosarcoma in this lecture, but we will caveat some of it with Portec 3, but this just talks about which trials included those histologies here. So feel free to take a screenshot of this, share it with your friends. I find it to be very helpful. Hopefully you do too. Let's get to it. So just like we alluded to, stage 3 includes the trials that include stage 3 disease, Portec 3, GOG-258, GY018, and Ruby. And then stage 4, 258, GY018, and then Ruby as well. Okay, before we get into all these trials here, I just want to draw your attention to one other trial, GOG-209. So this trial, which we'll go over, is the basis for why we use carboplatin paclitaxel in endometrial cancer, and which is why we have carboplatin paclitaxel in every other trial that we're going to be going over. So let's talk about it. GOG-209, it was a phase 3 randomized non-inferiority trial. Inclusion criteria were stage 3 or 4 and recurrent endometrial cancer with good performance status. The patients could have had prior EBRT as well as prior hormonal therapy, but they could not have had any prior chemotherapy. The two arms were TAP, or doxorubicin, cisplatin, and paclitaxel versus carboplatin and paclitaxel. The primary endpoint of this study was overall survival, and secondary endpoints included progression-free survival, quality of life, and toxicity. There were 1,381 women enrolled in this study. And the study concluded that carbotaxel was not inferior to TAP with regards to efficacy. And so given that carbotaxel had a more favorable toxicity profile and had also a small, potentially meaningful difference in quality of life measures, the conclusion was that carbotaxel should be considered first-line therapy for advanced or recurrent endometrial cancer. So that is a historical trial here for you that lays the basis for why we use carbotaxel in endometrial cancer and why carbotaxel is used in every single one of these other trials that we will mention. So let's move forward. All right, so let's get into it with Portec 3. So this was a randomized phase 3 trial. Eligible women had high-risk endometrial cancer. So based on the FIGRO 2009 staging, it was a stage 1, grade 3 with deep myometrial invasion, or LVSI, or both. Stage 2 or 3 endometrial cancer, or stage 1, 2, or 3 with serous or clear cell histology. The two arms were either EBRT alone at 48.6 gray or chemo-RT followed by chemotherapy. So chemo radiotherapy, so 2 cycles of cisplatin, and then followed by 4 cycles of carboplatin at AUC of 5, paclitaxel 175 milligrams per meter square. And this showed a slight benefit and a slight improvement in outcomes in failure-free survival with chemo-RT plus chemo in stage 3 patients. No overall survival benefit. And that was in the preliminary study or preliminary data of PROTECT-3. And then they did a sub-analysis to analyze patterns of recurrence and did a post-hoc survival analysis. And the greatest absolute benefit of chemo-RT plus chemo was found for stage 3 or serous cancers. They noted that these patients had increased benefit in regards to failure-free survival with chemo-RT plus chemo, with the caveat that this was post-hoc, but it could be discussed or considered, especially in this patient population. And these are the curves here. So if you go look at the paper and then look at the post-hoc exploratory analysis, you'll see the curves here with the differences. And then we have GOG 258. So GOG 258 was a randomized phase 3 trial. They tested, similar to PROTECT-3, a chemo-RT followed by chemo. So the 2 cycles of cis with radiation followed by 4 cycles of carbotaxol versus 6 cycles of carbotaxol alone in patients that had stage 3 or 4A endometrial cancer. There were 813 patients, and at 60 months, they looked at the percentage of patients alive and relapse-free, which was 59% in the chemo-RT group, 58% in the chemotherapy-only group. So at that point, it was concluded that it was a negative study. They did note that chemo-RT was associated with lower incidence of vaginal recurrences, as well as pelvic and periaortic recurrences. And then distant recurrences were more common with chemo radiotherapy. And then we saw at SGO that GOG 258 final results came out and showed no improvement in survival by adding radiotherapy to chemotherapy in endometrial cancer. And so I have a really nice quote here from Dr. Matai, who said the overall survival data from the study was eagerly awaited, and that for people who are still skeptical of the role of chemotherapy alone, this should put an end to that question. So this addresses that question, and there's that. Let's go on to the next one. Okay, so now we have GY018. This was a double-blind, placebo-controlled randomized phase 3 trial. There were 816 patients with measurable disease, stage 3 or 4A, or stage 4B recurrent endometrial cancer. So these were the 2 treatment arms in this trial were carbotaxol plus pembrolizumab versus carbotaxol plus placebo. The cycles, it was a planned 6 cycles of combination chemo plus immunotherapy every 3 weeks, and then followed by 14 cycles of maintenance every 6 weeks. And so the progression-free survival, they actually broke it up into the MMR deficient cohort versus overall cohorts. So MMR deficient, 74% progression-free survival with pembro versus 38% in the placebo group. And then in the proficient, not overall, but in the proficient group, the median progression-free survival was 13 months with pembrolizumab and 8.7 months with placebo. And last but not least, we have the Ruby trial. And so this was similar chemotherapy plus immunotherapy trial, phase 3, double-blind randomized, placebo-controlled trial. Eligible patients were stage advanced 3 or 4 or recurrent endometrial cancer. They were randomly assigned to receive either chemo plus dostarlimab or carbotaxol plus dostarlimab versus carbotaxol plus placebo. Again, every 3 weeks for 6 cycles, followed by maintenance therapy with dostarlimab every 6 weeks, or placebo if you were in that arm. There were 494 patients. 23% were mismatch repair deficient. And in the mismatch repair deficient population, the progression-free survival at 2 years was 61% in the dostarlimab group, and then about 16% in the placebo group. And then in the overall population, the progression-free survival at 2 years was 36.1% versus 18%. And then the Ruby trial did look at overall survival at 2 years, and it was in the overall population, 71.3% with dostarlimab and 56% with placebo. So there you have it, kind of a breakdown of all the advanced endometrial cancer trials. I would encourage you, especially with all the trials, but especially with GY018 and Ruby trial, go read the paper and look at the inclusion criteria, because you may have a patient with non-measurable disease and you need to know which trial fits which category. I will also say something that I didn't mention here. Ruby included carcinosarcoma, so that is a big win for the carcinosarcoma patients that fit into that category. GY018 did not include carcinosarcoma. So there, and I guess I did include that down here. There are a lot of nuances in each of these trials. I recommend that you print all of them, read them, go back to this lecture, maybe do some quiz questions on EmpowerMed, and take great care of patients. I have one more trial that I wanted to go over that didn't fit into here, and that's GOG 249. So we'll just do a separate one on that, because stage 3 for advanced wasn't included in 249. So we will go over that next, but in the meantime, please let me know if you have any questions, if something wasn't clear, or if you want to hear anything else. Take care.